We fully understand and are very, very well aware of the challenges that practices face at the moment. It's very, very obvious, but I'm not going to rehearse those. This isn't about the negativities today. This is about the positivities today, the things that you can do and the solutions. Today you're going to get a national picture from Professor Chris Ham. Steve Leitner later on is going to talk about what's happening in primary care home across the country. But it's very easy to provide people that can talk from far and wide. What about what's happening in your neighbourhood? We've got Dr. Nina Pearson and Heidi Newton. We've got Richard Moore, all from local practices, from Luton and from Lower Lee Valley in Hertfordshire. Local people doing great things. You're going to hear that these people are making a real difference to the care that they're offering to some of the most vulnerable patients that we have in our society. But they are also reaping tangible effects in their own practices about reducing workload by distributing it to the right people at the right time. They're making their practices more attractive to new doctors that are coming into work with them, and therefore they are becoming more and more sustainable. This afternoon you're going to hear from two very innovative practice managers that have also been able to put these changes into place in their practices. So we're not just talking about the theory, we're hearing about the practice of how to make it really happen. So I think today you're going to hear three very clear messages. The first one is that there really are fantastic opportunities to be had. I was going to make a quote from him in a moment, but there are fantastic solutions and opportunities for you to find. But the second message is that we really need to take a hard look at the business model of general practice to make it work, to decide whether it is working for you, your staff, and particularly whether it's working for your patients. And at the LMC, we too have gone through major changes and are looking at things very differently. And today we're launching the fact that we are setting about searching for the solutions locally and nationally, and we want to work with every practice to try and help you move forward and to face the future with optimism. What we're finding at the moment is we're hearing about practices that are really struggling, and we're hearing about practices that are terminating their contracts, but at the same time, we're hearing about practices that are forging forward, that are actually making changes, that are looking towards a sustainable future. Why is it that that's happening? What is the difference? What is it that practices that are really moving forward are doing that the struggling ones aren't able to do? We're trying to answer those questions at the LMC. The picture that's slowly emerging is that within those practices there's extremely strong leadership, very robust management. They're recognising that they're no longer a corner shop operation. They are what we call small to medium-sized enterprises, multi-million turnover businesses that need to approach it as multi-million turnover businesses. I was getting on an aeroplane a couple of weeks ago, and it dawned on me that the pilot is the expert in flying the aircraft. Well, I hoped he was. Actually, it was a she. I hoped she was. She didn't know about the HR issues of the staff that are going to be delivering the food to me. She had no idea about where the food had been sourced, I assumed. She certainly wasn't the key person running the timetable for the mechanics of the aircraft. Yes, she has some idea of how these things were working, but it's not her key role. So why is it that GPs expect to do these very complex functions within their practices? Why is it that they sometimes won't let the managers manage the practice? That's what they're paid to do. They aren't experts in everything. They are experts in what is becoming much more complex clinical care for their patients. So it's about looking at the way your business is run. I don't think I can put this any better than John Cotter does in this book here. He says, the basic systems, structures and cultures built over the past century cannot keep up with the demands being placed on them. And that's why we really need to take a close look at the business model we're actually currently delivering. Some practices are finding that more and more they're becoming less and less dependent upon their GMS contract for their main source of income. Why is that? How does that work? We're hoping today to give you some of those answers. I personally don't believe we can make such major changes in isolation. Practices need to be talking to each other. They need to be sharing good practice. They need to be sharing quality assurance. They certainly need to be sharing the learning that they're making whilst they're going through these transitional periods, in order that we can continue to lead primary medical services in a very different NHS. The LMC is so committed to helping to find solutions that we have employed a new member of staff, and Michael Harrison is at the back of the audience, I'm glad to say. The big disappointment is he can't start until the 1st of July, but we're trying to drag him in already and get his expertise. Michael has got a business background as well as a pharmacy background, and Michael is going to be leading our team on helping to support you to move forward in this quest for new business models and therefore new services for your patients. On top of that, we're being supported by the Business Management Department at the University of Bedfordshire. That's how committed we as an LMC are to help you to make these changes. So yes, these are really challenging times, but there really are fantastic opportunities both to help solve some of your problems today and to look at the future with more optimism. We can help you assess your business model very carefully and make suggestions as to how you can go forward. We're helping with the business planning for some of the practices going through the GP Resilience Programme at this moment in time. We want to be in touch with more and more practices. The LMC is here to help you to face the future with optimism. I hope you have a really enjoyable day today. The more you put into it, the more people you talk to, the more solutions you will find. Make networks. Enjoy your day. I'm going to move on now. Professor Chris Ham is Chief Executive of the King's Fund, has been there since 2010. He's a health policy academic and started life, it says, as a political scientist. An interesting title. He was said, according to his Wikipedia page, to have unrivaled in his ability to distill and synthesize complex policy developments and present them in a clear, digestible manner for non-specialists. He was also said in the Health Service Journal to be the 38th most powerful person in the English NHS in December 2013. What I like about Chris is that he never pulls his punches. He tells us exactly how it is. We hear him time and again. And he certainly doesn't pander to the powers that be. Chris, a very warm welcome and thank you very much.
Thanks very much, Peter. A little warm in here. So thank you very much for inviting me. I'm very pleased to join you for this first hour or so of your day today. I wanted to echo what Peter's just said. I have the privilege of working in different parts of the country, tracking what's going on in the NHS, both the opportunities and the challenges. And everywhere I go, I see two versions of the NHS. The first is the NHS that's been in the headlines during the winter, under pressure, almost in crisis, with ambulances queuing outside hospitals and concerns in mental health, primary care and community services. But But I also see the other NHS where there's a huge amount of change and innovation and improvement taking place, delivering more accessible care to patients, higher standards of care, and that's exactly what we need to build on. Both of those versions of the NHS are, of course, true and accurate. And again, to echo what Peter was saying in his opening remarks, the key, I think, is to try and accelerate those improvements and innovations as much as we can, while not ignoring or downplaying the workload pressures and the sense of crisis that is real as well. I also wanted to say, before I go through a few slides here, I have the privilege of visiting different countries around the world, not just in this role, but in previous roles I've had involved with the NHS. And one thing that struck me early on during my travels is how lucky we are with our system of general practice and, more broadly, primary care. Many countries have looked to us historically for inspiration and ideas on how they can strengthen their general practice, first point of contact services, develop a comprehensive continuity of care approach that we take for granted. And I think we need to remember that despite the pressures and the challenges, we start with a proud history, with a strong set of foundations. They are now being challenged, but there's a huge amount to build on. And we're still, I think, well ahead of most other countries in what general practice does, what it looks like, and what it can do more of in future. We published this report a year ago. My colleagues, several of them, did a study looking at the data. What's been the trend in workload in general practices around the country? And you will know far better than I. There is growing pressure, growing utilisation of general practice, both face-to-face, telephone consultations, and other forms of contact. But it's not just the volume, it's the nature of that workload, the growing complexity from an ageing population, an older population with frailty, with not just one condition but several, which means a workload of GPs and primary care teams is getting more difficult. Those two factors, quantity and quality and variety of work, help to explain the growing pressures that you and others in general practice are under. We also looked at changes in the workforce, the growing sense of crisis around early retirements, the difficulties of recruiting new doctors into general practice, but also changing career paths and career preferences. We spoke during this work to newly qualified doctors, and we found, again, what many of you will be familiar with, more and more new GPs not choosing to work full-time clinically, choosing to work part-time or to have more portfolio careers, combining clinical work with other interests. And that applies to men as well as women going into general practice. So the world is changing, isn't it? We need to plan for how patients are making different kinds of demands, how the staff delivering the care are changing the way they wish to work in future if we're going to rise to the challenges. So part of my message today, and one that some of you will be working on already, is that general practice must change. It must change to not only survive, but to thrive in the future. And in our work at the Fund, we've been arguing, and I summarise this as succinctly as I can on one slide. Primary care should lead, I emphasise that verb, should lead the improvement of integrated community services. We need health and social care teams in the community to be much more closely aligned with groups of practices in clusters, neighbourhoods, localities, to deliver that integration around people and around populations. That must include a broad definition of those community services, not just a narrow definition of what are provided within the NHS, but including intermediate care, social care, critically important given changing demographics, out of hours, and so on. And some specialist services, in our view, should work alongside integrated community services. We continue to struggle, in my view, with the historic separation that took place in British medicine 150 years ago. specialists being attached to hospitals, GPs doing work in the community, and the referral system from one to the other. That may have made sense in the 19th century. It does not make sense in this century. So not only must general practice change, specialist medicine must change. And that's not just a theoretical argument, it's already happening. We published this report back in 2014. Here's one thing I've learned on my travels around the world is other countries don't have that strict division. Other countries have an arrangement where there is multi-specialty medical practice, where there is co-location of some specialists with family doctors and the wider primary healthcare teams. And I challenge my colleagues to find some examples of where this may be happening in England. And they found 6, and it's written up in this report with quite detailed case studies, and I hope this might be of interest. All of these reports, by the way, you can look at on the King's Fund website, and you can freely download them. So in this report, Ruth Robertson and colleagues found examples in relation to the care of older people. Eileen Burns, a geriatrician up in Leeds. The care of children, the paediatric service in West London, based around Imperial. Work on diabetes in Hampshire, led by Partha Carr, the diabetologist, and I could go on. These are all examples, these 6 case studies, of specialists and their teams working across hospital and the community. Working alongside primary care teams, working in community clinics and community hubs, so that instead of patients always having to go to the hospital goes to the patients and goes to the primary care teams. And of course, you can't do this in all areas of specialty care, but you can do in many, if you like, the office-based specialties, and I've given you some examples. We also looked at Louise Restrick, a respiratory physician at the Whittington Hospital in North London, who works in this way. We looked at dermatology and we looked at rheumatology. And all the detail is in this report and the case studies that lie behind the report. If we're talking about integration, we shouldn't stop at the hospital door. We should be thinking about ways in which we can build those collaborations between specialists and generalists to centre the services around people and populations. So if you talk to Louise Restrick about the respiratory service in North London and the other examples, they're increasingly seeing a future of population-based specialty care. Not just caring for the patient in the outpatient clinic or in the bed, but caring for the population of people who have breathing problems in North London, or who have diabetes in Hampshire, or the population of frail older people that Eileen Burns and her team look after in Leeds, with a very strong link in that case to care homes and nursing homes, because we know that's where a lot of the care is done. Did you know there are 4 times as many beds in care homes and nursing homes together as there are in NHS acute hospitals? And there are a lot more, of course, in people's own homes, which is where most of the care gets delivered. But this is why we need to break down some of the barriers, the clinical barriers, the service barriers, the organisational barriers. If we start from the point of view of patients and people and population and communities, which is where we ought to start every time we think about change and improvement, not from the supply of care, but from the demand and need for care in our communities. And of course, some of these new care models of integrated community services are already out there. As the wise man once said, the future already exists, it's just not evenly distributed. And if you want to look at examples of this, the primary and acute care system vanguards under the 5-year Forward View New Care Model Programme in some of the places I've mentioned here. These are examples of hospitals leading the development of much greater integration of care. And it's no accident, perhaps, that some of our very best hospitals, as judged by the CQC in Northumbria and Salford, are indeed in the vanguard of integrating primary and acute care systems, bringing together the full range of services and linking with general practice and social care to do that. The other way of doing it is starting from general practice, which is where the multi-specialty community providers are so interesting. I mentioned just 3 examples. John Ribchester in East Kent, Stephen Short in Nottingham, colleagues up in Lakeside and elsewhere. Networks, groupings of practices coming together to build that platform and foundation for then linking with the wider range of the out-of-hospital community-based services. And often populations here, Nottingham, around about 125,000 people covered. In East Kent, it's bigger than that. It's about 170,000. Lakeside, last time I looked, was about 100,000. So quite sizable population groupings. Then, of course, the primary care home. And I know, Nina, you'll be giving a presentation on this later from some of the work you've been doing locally, but in Plymouth, Luton, Durham, and elsewhere. We've got examples much more around 30 to 50,000 populations, neighbourhoods and localities, clusters of practices, doing exactly what I was saying on the previous slide. It's all about this model of care. So change is already happening. We can look at some of these examples and see, and they're not perfectly formed, and there's still an awful lot of work to do, and there are different stages of development. Let me emphasise all of that, but they give some clues. They're converging from different starting points. They're all beginning to show what happens when general practice works at scale. Through federations and networks, it's practices themselves taking the initiative. But there are examples too in places like Wolverhampton, Newcastle, Yeovil, where practices are now working very, very closely with NHS trusts. They're looking to the management expertise and the support of acute trusts to help them through difficult times. And in a few places, we have super partnerships as another route. There are two in Birmingham. Modality is one. Our Health Partnership is an even bigger one. I went to the launch of Our Health Partnership about a year or so ago, and I've got my figures here. Let me just be clear so I don't mislead you on the on the numbers. Our Health Partnership in Birmingham covers a population of almost 300,000 patients, 150 partners, GP partners, and 50 salaried GPs working in Our Health Partnership. So there isn't a single solution. There are different models emerging in different places, depending on local preferences and the history and the context. And of course, a lot of the thinking behind some of these models goes back to the RCGP's report back in 2008 on primary care federations putting patients first. What I'm encouraged by in looking at many of these developments, especially those led from within general practice, this is not another government-mandated initiative. It's not a top-down policy that some bright people in the Department of Health have thought up. It's coming up from the ground, from the initiative of GPs, practice managers, others actually delivering primary care, and trying to find better ways of doing so, much more through collaboration. And quite a large proportion of the country now is covered by practices that have chosen voluntarily to get involved in federations, networks, clusters, and so on. Atul Gawande is an amazing US surgeon who writes in a very interesting way about developments in medicine and healthcare, and I really encourage you to do a Google search and track down some of the papers that Atul has written. He was a Reef lecturer for the BBC about 3 or 4 years ago, and he talks about the 21st century as the century of the system. And he talks about that obviously in relation to healthcare, but much more generally in relation to other aspects of our society and public policy. And the argument is we're faced with such challenging and complex questions, it's not within the power of individual organisations or governments acting independently to solve. We need to think about systems, not organisations. And that's exactly, of course, what's beginning to happen in our National Health Service. We are moving in the direction of systems based on sustainability and transformation plans. There is now a move to go beyond NHS trusts and organisations to create accountable care organisations, and sometimes they're called accountable care systems. We would argue in our work at the fund we need to go beyond that to think about health and well-being in the population as well as the integration of care, where the focus in all of this is on people and place. It's not a focus just on the organisations that we have at the moment delivering the care to the best of their abilities. And we've simplified and summarised this on the slide I'm showing you here. I hope this makes sense. If you think about individuals and populations on that vertical axis, and you think about care services and health improvement on the horizontal axis, we want all of these, I believe. So for us as individuals or family members where we need care, we hope we will get access quickly to high standards of care from the practice, from the hospital, from social care, individual care management. But for many years now, we've been trying to build on top of that, making every contact count. So when we turn up at the surgery, there's an opportunity, isn't there, to identify ways in which we can support our patients to live healthier through screening and other interventions, making every contact count. That's great at the individual level, but it's not sufficient. For a population, we need to find better ways of bringing together the expertise of different contributors to care. And that's where the integrated care models have gathered so much traction, and that's very much to be welcomed. Nobody seriously would want to argue for a fragmented, disjointed healthcare system. The needs of that growing, ageing population with complex comorbidity requires a joining up of clinical expertise and organisational expertise of the kind that is happening increasingly but needs to be accelerated. But the biggest prize of all, of course, is on the top right here, population health systems. Integrating care, but going beyond that to improve health and well-being by bringing in local government, industry, the wider societal contributions to deal with the fundamental determinants of people's health and well-being, which are not in the medical care system, they're in the society and the community in which they live. That should be the aspiration. And increasingly, that's where the ambition is. So where next? Before our very eyes, the NHS indeed is evolving in this direction. There are different systems depending on the size of the population and the problem we're trying to solve. A lot of the good work I'm aware of is happening in neighbourhoods and localities, which is really important because that's where most of us identify around the lives we live. Some of it is happening in towns, boroughs, counties, depending on the geography and where you live in England. And some of it's happening at the STP level. They're artificial constructs, but you probably need to work across a big geography like an STP if you're thinking about specialised services and helping hospitals to improve and deliver the right care in the right place. So it's systems within bigger systems within even bigger systems, working to integrate and improve population health. But whatever the size of the system, to reiterate, general practice has to be the key foundation stone because of the registered list, because of people's attachment to the practice, and because general practice is the key entry point for all of us and our family members when we need care and support. But, as they say on that television programme, not as we know it. We published a paper in 2014, myself and Rachel Addicott at the Fund, on the funding and commissioning and contracting changes that might move us in that direction. And we made the case for what we called family care networks. It's just a phrase to describe this vision of integrated community services led by general practice, encompassing all of the other contributors. And we suggested in some detail what kind of contract, what kind of funding, and what kind of management arrangements might be needed to achieve that change. I don't have time to go into the detail today, but all I would say is what we see happening in the multi-specialty community provider vanguards in places like Kent and Nottingham and elsewhere is a practical expression of what we were arguing for in this report. There are international examples we can look at as well. Peter was telling me there was a visitor here, Peter from Canterbury. In New Zealand, I've had the privilege of going to see for myself the model they have there. Anybody in this room? Was it in this room when Canterbury?
No,
Have any of you heard about the Canterbury model in person? Hands up. Okay. It's about maybe 10-15% of colleagues in the room. Essentially, the way they've moved forward is through an aim to integrate health and social care for the population of Christchurch in South Island, New Zealand, about 500,000 people, where they've suffered from dreadful earthquakes and earthquake damage for the population and for their buildings and housing in the last decade or so. But in relation to today's discussion, they have an organisation called Pegasus, which I suppose we would call a GP federation, set up many years ago now by the GPs to provide support for all of the practices in that area. Actually, there are only 3 that have chosen not to belong to Pegasus. There are always 3, aren't there, who choose to remain independent. And I don't mean that as a criticism, just that's life. And Pegasus is a key contributor to the success they've had in moderating the increase in demand for hospital care from their ageing population. They've invested hugely in their community services to avoid admissions where that can be done, to speed discharge back home from hospital where admission is appropriate, to provide support to practices. And Pegasus is an organisation that's grown, led by GPs, owned by GPs, to provide the support they need in their own practices to play their part in a truly integrated model of care. Another example from Seattle in the States is Group Health. It has the same values as we do in the NHS, community-based, community-governed by the population in Seattle who are served by it. And they redesigned their family medicine to deal with burnout among primary care team members, to make it easier for those teams to deal with those workload pressures by playing to the strengths of all the team members, by making better use of email and telephone contact, by streaming patients when they turned up at the clinics, and it's been written up and evaluated as an example of how that can be done. And I've mentioned already the value, if you look overseas, in some countries of having co-location of some specialists with primary care teams to deliver more of the work in a joined-up way in the community. Atul Gawande wrote this paper recently, The Heroism of Incremental Care. It's a celebration of general practice. It's a celebration of generalism. And don't forget, he's writing this as a surgeon. And he's saying, if we look, and he's writing more in the US context, but it reads across very well, at the growing demand and need from the population we have today, we haven't recognised sufficiently why generalism has to be at the heart of meeting that need. And in fact, at the King's Fund last week, we launched a new report where Jane Dacre, the president of the Royal College of Physicians, was with us speaking in response to that report, and she made exactly the same point. If I can quote Jane, her words, not mine, we need to sex up generalism. We need to sex up generalism to make it attractive, and she's thinking of general medicine in the hospital context more than in primary care, but it applies just the same, to deal with the growing workforce crisis in hospitals. 40% plus of vacancies for general physicians and for geriatricians were unfilled last year because newly trained physicians are choosing to become specialists rather than generalists. And what problems is that storing up for the future? Very similar arguments, of course, to ones in general practice. So if you want to feel reassured and good about the work in general practice, our tool will give you plenty of ammunition to support that. And always remember, as Martin Rowland and Sam Everington wrote in the BMJ, If general practice fails, the whole of the NHS fails. The whole edifice will come falling down because you play such an important role as the first point of contact in helping to deal with what we've been discussing this morning. So this is a kind of summary of several of the points I've been making. I guess given the time pressures, let me emphasise just those last couple of points. It's not about working harder, because you can't work any harder in most parts of general practice. It's how to work smarter and to work differently to reinforce why these new models of care are important. At the King's Fund, we've been arguing with our research the need for both investment and for reform across the NHS, including general practice. There are no universal solutions. I hope that's come over from what I've been saying with the examples I've been giving. The innovations we need have to be invented, developed and improved area by area and place by place. What works in Luton may not work in Bedford, may not work in Hertfordshire, and may not work anywhere else. So let's encourage these bottom-up innovations of the kind I know are already underway. I'll finish by showing you some data, which I hope will be a cause for optimism, given that's one of the themes of today. For most years over the last 30 or so, the British Social Attitude Survey has sampled the public and asked a selection of the public for their satisfaction with different aspects of public services, including the NHS. And you'll see very high levels of satisfaction throughout this period, sort of varying between 70 and 80% over a long period of time. And there aren't many public services which achieve that level of satisfaction, so something to be really proud of. And this compares general practice, which is the top line, with social care, dentists and the NHS overall. So a really positive picture here that really confirms what I was saying at the beginning about we've got a lot to build on, notwithstanding the pressures. This all comes down, in a sense, to you and colleagues out there doing primary care and contributing to the work of primary care teams. And just to be mildly provocative, only mildly so, I think there are some choices here for all of us when we go to work in the morning. Are we victims feeling hard done by, unloved and unvalued? Are we ostriches? We put our heads in the sand and hope it'll all go away and somehow tomorrow will be better? Or are we innovators? It is challenging, it's difficult, but the future is in our hands, working with our colleagues to find solutions to the problems, recognising that won't be easy, but do we want other people to find the solutions for us? Or do we want to do it ourselves within the emerging systems? We published this major report back in 2011, and I wanted to show you this as my penultimate slide, because again, it's a celebration of the change that's already happened in general practice. General practice today is very different from how it was in 1948, and there are many, many manifestations of that. And that's happened primarily from within general practice itself. RCGP, but teams all around the country, finding ways of delivering a wider range of care to a higher standard, more accessibly, much more leading change and meeting patients' needs. And we set that argument out in detail there, while also saying change is never ending. You may feel proud of what's been done, but there's a lot more still to be done. This is really important to hang on to in the challenging times that we work in. Another set of survey data. Ipsos Mori goes out from time to time to ask the public, what makes them most proud to be British? And hey, look what makes them most proud to be British. It's what we're all involved in different ways. Far more important than Marks and Spencer and John Lewis and indeed the Houses of Parliament, Royal Family and the Armed Forces. The NHS comes out number one. And the only reason I wanted to add that, apart from it makes us feel really good, doesn't it, is that we are in an election period and there are understandable questions and concerns about the impact on the NHS, whatever happens on the 8th of June. I worked in government for a short period of time, and one thing I learnt then is that these sorts of data are studied closely by the government of the day and their advisors. If this is what we think about in terms of what makes us proud to be British, I think it gives us some confidence whatever government we have on the 9th of June will think very long and hard about the funding of the NHS, its future, and how to support all of us to do even better in delivering great care to patients, but above all, improving population health and well-being. Thank you very much.
Chris, thank you very much indeed. I think we've got about 12 minutes for a few questions. I have to start the questioning off, Chris, by saying you gave us some very good examples of practices that have been moving forward, formed super practice and so on. If you was to give us a few words, what is the emerging picture within those practices as to how they've managed to do it?
Well, I think the answer, Peter, is that it comes through local leadership. It comes from moving beyond, this is very difficult and I'm not sure we're going to be able to survive. And of course, we know that practices have closed or are about to close or are thinking about mergers to deal with those pressures to, okay, let's take it into our own hands, to have visionary GPs and practice managers, and it can come from either of those groups or others besides, who are sufficiently persuasive to carry their colleagues along with them and to get sufficient support for actually putting in place some of these new care models. None of them is born perfectly formed. This is a stepwise process to move from the problem to the beginning of a solution to a better solution beyond that. But usually, in my view, it's a combination of GPs with practice managers or managers who are drawn from other contexts, who between them can provide not just the vision, but the practical resources and support that you need. And perhaps one thing to emphasise that I didn't talk about is if we're envisaging a future of general practice at scale, that will require a step change in the management support that's available to GPs and to practices to deliver these new models of care. It will require money and people and expertise of a higher order than is typically in place within the NHS at the moment.
Thank you. Open to the floor. Questions? You've been challenged. Do you want to be an ostrich, a victim, or an innovator? Dr. Swain.
Thank you, Chris. One of the things that intrigues me most is the contrast in the NHS. If I give an example, we're all saying, all the reports are saying, continuity of the care is the only proven part that will reduce admission and increase patient satisfaction and outcome. But how, I fail to understand how is this 150,000 patients with 150 partners are going to maintain that continuity? Can you explain me that?
It's absolutely the right question to ask. Sorry about that. We need to be clear when we're talking about these larger federations and networks or super partnerships. The practice will still be the basic building block. Patients will still be registered with the practice, and they'll still look to the practice as the first point of contact when they need care and support. And the practice will make its own arrangements for delivering that. The benefits of working at scale are you can more easily then achieve the alignment with all the other community services and get closer contact between what the practice can do, what the community teams are able to do, with social care being very much part of that. That larger unit, let's call it a federation for the sake of argument, can provide a lot of the support that practices generally will need around IT, around workforce, recruitment, retention, workforce development, around business management, around all the other things that practices require and do today that perhaps could be done better through this more collaborative model.
And the trick we have to bring on is to ensure absolutely that patients get that continuity of care and continuity of carer where that's the right thing to do, as well as providing the kind of access that the public expects as well. I'm not a great fan of what the government's been trying to do in the last 3 or 4 years, around 8 to 8 opening hours, 7 days a week. But if that's going to be a requirement, and the government of the day has every right to say it's a requirement, that requires practices to collaborate to deliver that kind of access. I think for some people, access will be as important as continuity. We have to have a model that's capable of delivering both, depending on the patients and their needs.
Thank you. Yes, Christian Harris at the back.
Thank you. It's been very interesting, and you made some great points. I particularly like the idea of having integrated clinics within practices, because I'm still waiting for a letter from a psychiatrist who saw my patient last November, and I thought if they'd seen him in my practice it would have been in the notes and I'd have known that what their recommendations were. But what I really wanted to do was just to build on the point that you've just made, really, that one of the things that just occurred to me to listening to what you said was that over the years GPs have kind of accepted that they have to do everything. They have to be Superman, they've got to be the social worker, the financial advisor, the housing officer, write letters for schools, help children who need placement somewhere. If we get into a system where we are working as a multi-specialty group, maybe we could actually understand that we need to get on with doing the medicine side of it and actually give things to the people who are qualified to do the other jobs, which is what Peter said in his opening comments. And I just think that point has been made really clearly today. It's certainly opened my eyes a bit.
Did to deal with burnout and workload pressures on the physicians in their system, because in their model they have list sizes for individual family doctors of 2,000. They're able to cope with that because they're using the wider team, using different forms of contact with patients, and it works for them in their context.
There's something about how do we get patients to change their attitudes as well. Patient until you've seen the organ grinder, you're not happy to see the monkey. You've got to see the GP. There is something about changing attitudes for patients. Any more questions from the audience?
As a policy person, what is the evidence that bigger is better? The government seem fascinated by this, and clearly, for me, stronger, better organisations are better, not necessarily bigger.
So, I think the question's a really good one, but my challenge back is it's not either or.
Could you repeat the question?
So, sorry, the question was, where's the evidence that bigger is better in relation to general practice? So, my response is, we don't have to choose between big and small. No. So
we're being pushed to merge.
Well, so the point I just made in response to the previous question, if we're moving to a world of federations and networks, that still means the practice remains the basic unit through which care is delivered and the unit to which patients look when they need care and support. But practices voluntarily, nobody's making this a requirement, are seeing, well, I mean, you raise your eyebrows. Is anybody being forced to merge and collaborate with other practices? I know many are choosing to do so, but is anybody being forced to do that?
Where in the SDP model say anything other than big organisations, healthcare, home, all these?
There's a very strong argument.
Okay. But
you can't have money if you don't.
So I can see that there'll be incentives to encourage them to come together. But all the developments that have occurred since the RCGP advocated federations in 2008 have happened through practices and primary care teams choosing to come together. And sometimes it's on quite a small basis. So clusters and localities, 30 to 50,000, the primary care home model. I gave you the example of Birmingham, where it's almost 300,000. The GPs in the Our Health Partnership in Birmingham don't feel they've been strong-armed into creating their own organisation to look after their interests. They've said, well, life is tough out there. We can't continue as we are. Some of us will retire, some of us will go into mergers, some of us will close our practices. But those who've chosen not to do any of those things have chosen to create our health partnership to be a vehicle for them that would enable them to continue working and delivering the care they wish to deliver. It's still an open question as to whether these bigger models, particularly at that size, will deliver the improvements in care that I think we're all hoping for.
So the answer to my question is unproven.
Absolutely. I think that was clear when I went through the different models, the NTPs, the PACs and the primary care homes. They're all interesting to look at, but I can't stand here and say this is a better model than that model, or indeed better than the current model.
I think we've got time for one more question. Dr. Cruikshank's behind you. Sorry, Dr. Parker.
In your opinion, what's the best size for a primary care organisation?
There is no best size.
Okay. So, what benefits are there of being, say, the Canterbury model where it's $1.5 million,
Half a million.
to the size around 50,000 or grouping around a town?
So it really depends, form and function. The size depends on what you're trying to do. So in Canterbury, across 500,000 people, it's about supporting the practices to continue to survive and thrive as individual practices by providing them with a lot of the support that individual practices simply can't provide on their own. It's about their IT systems, it's about their workforce development. It's about, in their case, building much stronger links between family doctors and specialists. So in the case of Canterbury, they have what they call a system of health pathways developed in collaboration between the GPs and the specialists at Christchurch Hospital, where they take the main medical conditions that present in their population, and they've agreed pathway by pathway what good care looks like. What patients should expect in the surgery, in the hospital, and in the relationship between the two. That's been so successful for them, it's been copied in other parts of New Zealand, it's been exported to Australia and elsewhere. So if the aim is to define what good integrated care looks like for major medical conditions for a population, you need to do that at scale across 500,000 people. If your aim is to say we've got within our locality a number of people who require quite intensive support from a range of different health and social care professionals and providers to enable them to live independently in their own homes and to avoid inappropriate hospital admission or care home admission, you can almost certainly do that at a population of 30 to 50,000, where it's better to do it at that level, because the knowledge about who those people are and how you identify them and how you support them is much more readily available at a small population than it is at a much bigger population. Horses for courses.
I'm going to draw this session to a close. Chris, thank you very much for a very, very stimulating and thought-provoking opening to our conference, and I think the discussion and debate will continue. Thank you.
Thank you.